Hello, ladies and gentlemen, and welcome to the Crown Hotel in Brackley. This is the 8th of 15 planned meetings for the big health and care consultation for Oxfordshire Transformation Programme. My name's Gavin Grey. I used to live and work here in Oxfordshire and the borders into Northamptonshire, working for Central Television. I've been a journalist for a few years, and I'm not part of the panel. I would just, as my role today, to get as many voices heard as possible from the audience, questions, concerns, and anything else that were put to the panel. Inevitably, with these things, we tend to run out of time because I do want to let everyone know it is a 2-hour meeting so that you don't think we're going to be here for hours and hours. And if anybody, however, wants to ask a question a little later on, do feel free. If we don't get to everyone, I'll come to various ways in which you can get your question answered if I don't manage to get to you during the course of this meeting. As I said, it's my role to get as many voices heard here, and most of the 2 hours will be taken up with questions and answers. Just a quick bit of housekeeping. This is a public meeting, and I would welcome Roseanne here from the Banbury Guardian, but I would equally say, therefore, that everything is effectively on the record. That includes members of the audience. And if there's anybody who doesn't want to be in a photograph that Roseanne may take for the newspaper, I would alert her to it, or sit at the back is probably a very good idea. It is, of course, a no-smoking venue. If you've got a mobile phone, I was just reaching for mine a moment ago, can I ask you to switch it off or to mute? The toilets are at the back, and just before you hit reception, go to the right. I would suggest, for the sake of these poor people sitting here, that we don't use the toilets here, because I think there's plenty of space outside for those. After a brief discussion with the manager, there is no fire alarm practice. So if the fire alarm goes, it is genuine, and that's an exit, and that's an exit, and apparently the meeting place is in the car park at the back. So out towards Waitrose at the back there. OK, the schedule will be, I'll introduce the panel members and get them to say a few words about themselves. Then we'll have a presentation and a short video. Now, a lot of you will think, well, you know, I've read all about this, I know what it's about. There's a lot to it, as you see from the packs here, and I think it's important to hear from the people putting the proposals together, that you hear from them some of the main points. It'll also then, I think, enable you perhaps to frame your questions and answers perhaps a little bit more specifically. And then we'll move into the question and answer session, and with a few minutes to go, I will then draw the questions and answers to a close and just ask if any of the panel members here want to ask or wrap up with any concluding points and things that they've heard today. So just looking along the panel members that we've got here today, some of the faces you no doubt will recognise, and working from your right to left, we have David Smith, who is the chair of the Oxfordshire CCG, Dr. Joe McManus, who is an Oxford GP and clinical chair of the CCG, the Clinical Commissioning Group, and then Catherine Stoddard. Now, she's the chief nurse at the Oxford University Hospital NHS Foundation Trust. Then Dr. Kieran Collinson, who is a GP from West Oxfordshire and is the lead for maternity on this particular transformation proposals of the CCG. Andrew Stevens, Director of Strategy and Planning at the Oxford University Hospital NHS Foundation Trust. And at the very end, last but by no means least, Sula Wiltshire, the lead nurse from the CCG as well. Apologies to those sitting on the far right. You're probably blocked out by that screen. We've tried a lot of different things to prevent that, but it's a bit of a cramped room. But it's lovely to be in the centre of Brackley and also at the Crown Hotel. OK, so I've introduced who they are. Perhaps we ought to hear a little from them about their various roles now within the CCG. And perhaps if I can ask David to kick off, the chair of Oxfordshire Clinical Commissioning Group.
Yeah. Good morning, everyone. David Smith. I'm actually the Chief Executive of Oxfordshire Clinical Commissioning Group. Oxfordshire Clinical Commissioning Group, we are responsible for leading this consultation. We're running a number of meetings across the county, but also outside of Oxfordshire. I'd just like to thank you for coming today. We've got a very short presentation and some videos, but most of this meeting is your questions and answers and comments. Thank you.
Dr. Joe McManus.
Good morning. My name is Joe McManus. I'm a GP and the chair of Oxfordshire Clinical Commissioning Group. I'd just like to say thank you for welcoming us here in Brackley.
Hi,
Catherine
everyone.
Stoddart.
Oh, sorry. Hi, everyone. I'm Catherine Stoddart. I'm the Chief Nurse for the Oxford University Hospitals Foundation Trust, and I have professional accountability for nursing and midwifery in the Trust and the workforce that's associated with it.
And Dr. Kieran Collinson.
Hi, so I'm Kieran. I'm a GP. I work in the west of Oxfordshire. I lead on the maternity work that we've been doing. And I've got kids of my own, so it's an area that's very close to my heart.
Andrew Stevens.
Good morning, I'm Andrew Stevens. I'm the Director of Strategy and Planning. That means I work with our clinical colleagues, both within the organisation and across other organisations, to plan services for the population.
And lastly, Sula Wiltshire.
Good morning, everybody. My name is Sula Wiltshire. I'm the lead nurse for the Clinical Commissioning Group. I've worked in Oxfordshire since 1980, long time ago, and I've worked across all sectors in healthcare.
All right, so that's the panel. You have all the experts here today. Now, when it comes to the Q&A, which will be after the presentation, which we'll hear, I know not everyone likes speaking in public. It's not my favourite thing either. So if you don't want to actually stand up and ask a question, we've got some postcards and pens. Feel free to write your question down. We've got a number of different assistants and helpers who will bring those questions up, and I will try to get those answered. If, however, I either don't get to you with your hand up or that question doesn't get asked, they are all going to be written up onto the website, and then the answers will be posted up on there. So plenty of things to get through today. Let's start with the presentation and the Chief Executive of the CCG. Sorry, David.
Okay, thank you. I just want to set the scene. I've got about 3 or 4 slides and take about 5 minutes just to set the scene, and then I'm going to hand over to Dr. Joe McManus, and we've got 5 very short video clips which feature a number of the consultants particularly from the university hospital. So all in all, this will probably only take about 15 minutes. So most of today, as I said before, is your questions and your comments to us. So we're consulting for 3 months from the 16th of January to the 9th of April on a number of changes. And these are the changes in this first phase of consultation. Use of hospital beds, that's across the whole of Oxfordshire. Secondly, what we call planned care at the Horton Hospital in Banbury. So proposals around increasing the number of outpatients, day cases and diagnostic tests, things like x-rays, that can be done at the Horton. Acute stroke services in Oxfordshire, critical care at the Horton, and maternity services at the Horton. So that is in our first phase of consultation. We will run a second phase of consultation later in the year on some other proposals. And again, we can pick up some of the, if you've got questions on that later on. So why are we consulting? What's our case for change? So just to pick up a number of these issues. So you can read them there, but just to try and explain the issues that we're dealing with. And clearly, NHS is very topical across the media in terms of what's happening across the NHS. So just to explain some of what's happening that we are seeing. So our population is growing and our population is getting older. We are seeing year-on-year increases in the number of people who are presenting to be treated, and that's whether they're presenting for treatment and consultation within GP services, within the hospital or within other parts. So our population going up and our population is ageing. We want to improve the quality and the safety of care. So some of our proposals, and I know we know that some of this is controversial, and I'm sure that will come out this morning, but some of these proposals, they are about improving the quality and the safety of care. And I think you'll hear more of that as we go through the question and answer. There are inequalities. We've got inequalities across the county in Oxfordshire, and that's in areas like the cities, so in Oxford, in Banbury, but also in some of the more rural areas. We want to invest more in prevention because we know investing in prevention to support people before they're ill actually reduces the demands on our services and is obviously better for individuals. So we want to do more on prevention. Across the whole of our area, and this is typical of the NHS as well, workforce. So the staffing issues are a significant problem that we have. Recruitment, retention of staff, clearly not helped by very high house prices in our sort of area. And then that leads on to the buildings and equipment. And again, if we look, I'm talking very much about Oxfordshire. I'm sure conscious that we are just across the boundary here, but there will be questions from you about particular areas around Brackley and the surrounding villages in Brackley. But if we look at our physical estate, our buildings and our equipment, we actually need to do more. We need to spend more money on starting to have buildings which actually will deliver modern healthcare. And lastly, on the money we get all of our funding comes from the government. I'll happy to pick up questions later on if people have got specifics on this. The amount of money we spend, it is going up year on year. It's going up about 2% year on year. However, that resource is not keeping pace with the level of demand that we're seeing. So more patients are being treated. We're not getting enough money from the government. And I think, again, happy to pick up that later on. So those are the reasons why we're consulting. Lots of questions. I'm sure it will come up later in terms of, so why are you doing this consultation in 2 phases? Why aren't you doing it all together? Firstly, because there's a lot of services across the whole of our county that we need to consult on. But some of these services need urgent changes. So acute hospital beds, where there have been a reduction in acute hospital beds within both the Horton and the John Radcliffe hospitals in Oxfordshire. And we were asked to go out to consult on those by the Overview and Scrutiny Committee. We need to then consult on the maternity services at the Horton, where there was a temporary change in that service from October. And also we have proposals about critical care and stroke, where we believe we need to make those changes, and we should do that now. However, the other part of this consultation is around how we believe we can provide more care for people in the Horton. So that at the moment, a lot of people are going in for outpatients and diagnostic tests into Oxford, and they could provide that, have that service provided at the Horton. And again, very happy to talk later around, so what are our plans around that, and we'll pick up on that. So finally, so our vision. So what is our vision? What are we trying to do here? So firstly, local access to diagnostics and expert advice, because that's what a lot of patients want. They want to see local GP, they want to be referred, they want to be treated quickly, have that diagnosis. Secondly, it's preventing the unnecessary admission to hospital or attendance at an A&E department. We use technology. Again, we live in that technology age, but if you look at the technology that we use in the NHS, we've got a very, very long way to go compared to other parts of the way we run our lives. And then the final issue is around this issue that we say, you know, like our catchphrase on this is around the best bed is your own bed. And really that's saying actually that we want to get paid. If we can stop admission into a hospital, we should do that. But if you've been admitted into a hospital, being able to actually go back home as soon as we possibly can, rather than, as we all know, around the number of delayed patients who are delayed in hospital, the sort of the bed blockers, as people would call it, who are delayed in an acute hospital bed, and they should be back at home and being cared for in home. So that is what we're trying to do. So I'll just come back at the end. What I want to do now is to hand over to Dr. Joe McManus. Joe is our clinical chair and is a GP in Oxford, who will just introduce, as I say, 5 short videos which are the consultants talking in a bit more detail about these proposals. Okay, thank you for listening.
Thanks very much. So, again, good morning. Before I go on to the videos, I just want to expand on a little bit what David was just saying, really, which is what's happening in the NHS generally. And I think it's really important to think about this consultation as just one part of a major set of changes the NHS is having to go through, probably over the last few years, but also over the next 10 years or so. This consultation is a small part of that. And that's something that struck me speaking to some of the patient groups who said, well, look, there's a lot of things that we're interested in that isn't in this consultation. Why is it just limited to this? But actually, this is a part of the service changes that are pretty urgent that need doing at the moment. But there's an awful lot of that's been going on recently and will be going on in the next years to come, which is trying to get the NHS into more of a stable footing, which will be sustainable for the future. And it's worth just thinking about what are the things that are driving that. David mentioned about an ageing population and more demand for healthcare. So we know that demand for healthcare is going up more than the resources. So what we have to do collectively is try and figure out how we get the best value for the resources we've got, and particularly today is about how we use our hospital in the right way, how we use the John Radcliffe, how we use the Hort, and how we use other hospitals as well to get the best value for patients. And what's driving that is we've seen over some years now. I started as a GP about 12 years ago, and even in that time, I've seen the number of people who have to go to hospital going up and up and up. That's not just people being admitted using A&E, it's also people having scans, people having outpatient appointments. So if we continue doing that, we're going to have to build lots more hospitals, which we know we just can't afford. But also, we don't really think that is the best model of care. So some of this is about how we use the hospital in the right way. And I'll just use a couple of examples on that. So first of all, this particular bit is about acute hospital beds, which basically means if you have an emergency and you need to go to hospital for an admission, it's about how we manage your care. And it is saying it's not just about putting you in a bed for some days and then discharging you again. It's a lot more sophisticated than it was 12 years ago about how we actually manage somebody who's unwell. So this first clip just tells you an example of what's happening in the John Radcliffe, but also it applies to the Horton as well about what the acute hospital teams are trying to do when somebody's unwell. So, does it just...
Mum had a bit of a fall from her chair. She has dementia and she's disabled. I picked her up off the floor and it looked as though she'd had a stroke. I called the ambulance and they decided that she needed the hospital.
The Liaison Hub is a team of multi-professionals who are working together, based at the hospital, but the most of their work is actually carried out in the care home beds across the county.
Staying in hospital for the full extent of one's recovery is neither necessary nor desirable. Reducing exposure to other people who are unwell, reducing exposure to infections by moving into a hub facility increases the probability that someone's transition into wellness is going to continue without being broken up by the harms of being in a hospital environment. There's a huge psychological component to being cared for. Within 3 days, many particularly older or more vulnerable people will become incontinent, whereas previously they weren't, just by virtue of having the availability of someone to look after your most basic needs. So by expediting a transition from being in a cared-for hospital environment to a much more natural, homely environment, still within the support of a nursing home or care home, then we can make sure that we're avoiding that increased dependence which a lot of patients experience. We no longer see care as being a black or white division between pure hospital care until you're fully better and then discharged home. We don't like the idea of discharge.
Radcliffe told me we managed to find you a bed in the nursing home that your wife's in. And I said, well, just thought it'd be good companionship for you, nice and be together. And I very much enjoyed it there, I really did.
I've seen really great results from people being enabled to get out of hospital, continue to have their rehabilitation and care, but in a setting that is much more homely. The Liaison Hub is a key component for ensuring that the whole system is using its capacity efficiently. I'm absolutely certain it's helping patients. The patients that I've worked with have really thrived.
The Liaison Hub made such a difference to us because actually it got Mum to the place that she really needs to be. I can't thank them enough. I'm really pleased with the way things went.
Thanks. So again, that's an example of about how we actually can use the hospital in the right way, and how it actually would look if you're a patient. I mean, as a GP, a lot of the time we admit people to hospital, or people are admitted to hospital who have some uncertainty about what's wrong with them. So a typical example would be a an older person with dementia who becomes a bit more confused, and we don't quite know what's wrong. And the old way of doing things, which still happens, is that you admit somebody to hospital, they go to a bed, and then have various tests over some days, and then eventually somebody figures out what's wrong, and then they're discharged again, but often they have to wait some time for a care package or for a nursing home. We know that if you spend a long time in hospital, particularly if you're an older person, then that's actually not particularly good for you. So what we really need to do is get the diagnosis really quick, right at the start, ideally on the same day. And if you can do that, you can get somebody home straight away. And certainly you can start planning the actual care package and what happens in the community first. The liaison hub is there about supporting people outside the hospital as well as in the hospital. And the idea is that you don't use the hospital just for people coming in, and that's the end of the role. You extend the role so it supports people in the community more. And we know that if we don't do those things, then more and more people will have to be in hospital, and they'll be stuck there for a longer period of time, which is not in their interest, and it's also not the best use of resources. So what we're proposing as part of this is more investment before you get to hospital, more investment on the diagnostics and the assessment on the day, and then more investment in people to support you or your relatives when you're at home. If we do those things, then people will spend less time in hospital, which will save money, which could be spent on providing more support in the community. If we just flick on to the next slide. Yes, so the proposal for the hospital beds is that we will invest more in the community, invest more in assessment, and we will therefore have less need for hospital beds. And we can talk more about that. So planned care, by planned care, we're talking about outpatient appointments, diagnostics, including MRI scanners, CT scanners. And the proposals here are particularly focused around the Horton, but it's also what's driving this is the fact that more and more people do need hospital appointments. We're seeing quite a big growth in that. More and more people need scans and diagnostics. And there is absolutely no reason why you need to go to a very specialist centre to do that. So the more we can do closer to people's homes and places of residence, the better. If we can do more diagnosis in the community, if we can do more outpatient appointments, which are closer to where people live, that reduces travel time. That actually is a better way of doing things. So part of this proposal is to increase the amount of outpatient appointments and scans that are done at the Horton. And the numbers are about 60,000 per year. And we'll just have a little flavour of that.
Planned care is care that occurs outside of an emergency situation. And the three main components would be diagnostic tests, including imaging investigations such as CTs, X-rays and MRI tests, outpatient appointments, and procedures that don't require to be performed as an emergency situation. Currently, a lot of patients have to travel to Oxford for various procedures and investigations, and if we could enhance the facilities within Banbury, then we could prevent those journeys from having to be made and try and deliver care to patients closer to their home. Looking at the catchment area of patients that travel to Oxford, it's projected that approximately 60,000 patients per year could be having their procedures and investigations in Banbury and not having to travel to Oxford for those investigations and procedures. To be able to deliver those services locally, we'd need to build a new state-of-the-art facility which would include diagnostics, outpatient facilities and improved access to certain day case surgery and routine outpatient procedures. We already perform some chemotherapy and renal dialysis treatments in Banbury, but the plan is to enhance those facilities and increase access to more patients to be treated locally. Patients often have to attend hospital for several different appointments to have their investigations and their outpatient appointments and get their results at the end. So what we plan to do with a one-stop shop is to try and reduce the number of attendances patients would have to make. So although we're trying to deliver care locally to Banbury, we also want to reduce the number of appointments patients have to make to achieve their diagnosis and treatment.
Yes, so I won't go over the slide again, but that's the proposal, and we can have some more discussion on that. So the next area is stroke care, and again, what's driving these proposals are basically a change in the way that we deliver medicine and healthcare, particularly for areas such as stroke, and we'll go into critical care and maternity. And it's the realisation that for certain problems and conditions, it's much better to have very specialist care. And by specialist care, that means specialist teams who are used to working on a particular problem 24/7 and are very, very specialised and have the expertise to be able to manage that. If I go back to, again, when I was a medical student, every hospital used to do a bit of everything. And it particularly changed with cancer care, which was a while ago now. But the realisation was there that if every surgeon tried to operate on cancer, you got worse outcomes. And the realisation was that you should have very specialist surgeons who deal with cancer patients, and you get much better outcomes because they're doing it every day, day in, day out. And in the last 10 years, stroke care has revolutionised. There's been a much better treatment pathway. Before, with a stroke, you would basically be looked after in hospital. It was mainly nursing care. Now we have thrombolysis, which means clot-busting drugs, and also you hear about thrombolectomy, which is removing surgically the clot which causes a stroke. And if you do that very quickly, then you actually get a much better outcome. And you can only do that on a certain number of sites. So you need to be in a specialist site to have that done. It's not possible to do that everywhere. And what we also know is that the number of people who are able to do that is limited. So we have a specialist site at the John Radcliffe called the Hyperacute Stroke Unit. At the moment, almost everybody who has a stroke will go there, about 90%. So this proposal is to make that pretty much for everybody who has a stroke in the catchment area, but also to expand the amount of care that's delivered at home for people who have a stroke, so you can have more rehab at home.
At present, we have an access of all patients to the John Radcliffe for immediate assessment driven by 4 hours from onset. With the transformations that have been undertaken in stroke care in the last 18 months or so, where mechanical thrombectomy, where we use devices to pull out clots rather than just using drugs, we need to get patients to the John Radcliffe to enable equitable access from the whole county to this life-changing treatment. This is a very intensive, highly specialised intervention that very few centres in the whole of the UK can provide. And we're very fortunate that we have one of those centres here in Oxford. We also need to provide equitable access to the rehabilitation that enables the best recovery for patients. Through the early supported discharge service, which we hope to expand from the 6 postcodes it currently covers to the whole county, we hope that we will enable patients to have therapy in the comfort of their own home, enabling them to have therapy targeted and ensuring that they maximise their chances of returning to functional independence in the environment where they're going to spend the rest of their lives. And that's the whole purpose of the ESD being incorporated, early supported discharge, incorporated into this consultation. When it comes to immediate access to a hyperacute stroke unit, the major benefit to patients is the immediate assessment with specialist imaging and access to immediate specialist assessment by consultant staff, both physicians, such as myself and my radiology colleagues, where we can make the immediate decision whether mechanical thrombectomy is potentially helpful to patients. This is a decision where an immediate assessment and immediate decision really do enhance the chances of patients returning back to how they were prior to their stroke.
So that just highlights what I've just said. So the next area is critical care. Again, what's driving this is the need to have specialist care delivered by people who are used to doing it 24/7. I'll play the video and then I'll talk a bit more about it. But it's again mainly focused on the Horton. But the proposal is that we make the John Radcliffe the major centre for critical care, and I'll explain a little bit more about that.
We have 3 adult critical care units at Oxford University Hospitals, 1 at the Horton, 1 at the Churchill Hospital, and 1 at the John Radcliffe Hospital. I suppose the levels of care reflect the complexity of care delivered to the patient and how sick they are. Level 3, which we sometimes call critical care, are for much, much sicker patients. These patients need advanced respiratory support, which is really the breathing machine, the ventilator. Critical care medicine is like everything else in life. The more you do, the more it becomes routine, and the surprises, the less they become unusual. If, as in the Horton, in the last year we had 40 level 3 patients, that means that's less than one patient each week, and in reality probably less than one patient a day. And that takes it into the numbers that makes managing them not routine, not normal business. Critical care facility at Oxford, there are about 1,900 patients there each year. So you can see immediately how the care of a critical care patient, which is never routine, but the general aspects of the care of a critical care patient becomes much, much more routine simply by having those numbers of patients.
So just to clarify, this is not about not having any critical care at the Horton, but level 3 is the most sick patients who usually will need ventilation and intubation. And the small number at the moment are seen at the Horton per year. And the general consensus is that isn't a very safe situation to continue. So to make that much safer for people who do need that very intensive care, that needs to be on a site where people are doing that day in, day out again. But they would still have level 2 critical care, which is more high dependency support. And then finally we have maternity. So I assume you will know a fair amount about this, but if you don't, what happened last autumn was that the Horton obstetric-led unit was temporarily closed, and I'm sure we'll talk more about this. But what was particularly driving that was the difficulty that the Oxford University Hospital Trust had in recruiting middle grade doctors. So you need to have a specialist rota of consultants to run an obstetric-led unit, but you also need to have a substantive rota of middle grade doctors to be able to do that safely. And they simply weren't able to recruit those doctors over time. And a lot of what's driving this is that there's a national shortage both of consultants but also of middle grade doctors. But the proposal is to have the obstetric-led unit a midwife-led unit on a permanent basis. So we'll play the video and then I'll just add a couple more points.
We want to provide a high-quality, safe and sustainable maternity service. And although we provide a great service at the moment that I'm very proud to work for and work in, we can still do better. And if you look at women of today, we have sort of two groups of women. We've got a much fitter, healthy group of low-risk women, and we've got women who have more complex pregnancies. And actually, we want to design or update our service so that women can get the best outcomes for themselves and their babies and their families. So to do this, we need to look at the service that we provide and how we can make it better, make it more sustainable, and get the right women to go to the right teams.
The most important element of care for women in pregnancy and during labour is about making sure that they've got the right information to make the right decision about where they have their care and by whom. So that would be done in partnership with the woman and also her professional lead, which could be her midwife or her consultant obstetrician, depending on her pregnancy, and also her labour, her likely labour. So for women during the antenatal period, it's important that there's a risk assessment at the beginning of pregnancy to determine where they should have their care. So it would be about the right place with the right team. So if you've got a woman with a higher risk pregnancy, then there would be a requirement for them to have medical input as well as care from their midwife. But if they've got a low-risk pregnancy, then for the majority of the women, they will have their care with their community midwife with some input from their general practitioner, which is also important.
The main challenge in maternity is recruiting obstetric doctors. So to recruit doctors, we need to make the jobs attractive, and we need to provide the doctors opportunities to train and to maintain their clinical skills. And currently, this is challenging, particularly in the smaller units. There's basically not enough clinical experience and clinical scenarios for the doctors to remain updated. Interestingly, there's a lot of information now and evidence that shows for these fit, healthy group of women, which most women are, they in fact do much better in low-risk midwife-led units. There's less clinical intervention and they get a much better experience and get home quicker with their babies to their families. However, for some other women, their pregnancies are more complex. And actually, as the health service developed, we've now found that these women, they do better if they're under the care of more specialist teams and have a different group or team of professionals looking after them.
So this slide just highlights the option that's been presented, and that option is something that, as a team, we feel is the most feasible and safe, sustainable option on the table. And I'm sure we'll come back to some questions about that. So the consultation documents are all on the website. As we've heard, there are a series of consultation events, and there is a second event in Brackley, which I'm sure we'll come to afterwards. We talked about phase 1 and phase 2, and again, we can answer more questions about that in detail as part of the question and answer. Yes, here we have a list. So we've got today's one on there. Yes, we've got the second one on there as well. And I think there isn't a venue confirmed yet, but the time is confirmed and people can register for it if wanted. Okay, well, thank you very much for listening. Much appreciated. And I'll hand you back to the chair.
Okay, great. Thank you very much indeed for that. And thanks as well for everyone for listening and sitting through that. I'm hoping it was instructive and will enable you to better focus your questions. I'm delighted to say today we've got councillors in the audience. We've also invited Victoria Prentice, MP. Sadly, she's got other business, of course, at the House of Commons, but we're delighted that some members of her team are here, along with her father. But it is actually not just the councillors, not the elected people, it's the ordinary residents of Brackley and the area that I'm really, really keen to hear from today. I'm not dismissing them in any way, but I'm very keen to hear from ordinary residents. So we have the panel of experts here. I will get through as many questions as possible, as well as sticking your hand up. If you could introduce yourself before you start. We've got microphones that will come to you. Please, therefore, just don't start trying to shout from the back. We'll get microphones to you so everyone can hear. But if there's anyone who wants to ask something, having seen that presentation, but wouldn't really like to stand up and speak, then we do have postcards and pens on which to write the questions. And I think some of the assistants will bring those up at various points. And then I will try and put as many of those to the panel as possible. Forgive me if I chivvy you along if you're taking a bit of time. I'm just keen to hear as many questions as possible. So, without further ado, let's start. Okay, I'm going to start with, for sake of argument there, Victoria Prentice's father, but after that we will go to, as it were, local residents. I see some other hands up as well. So, first of all, yes, sir.
My name's Tim Boswell. I am, as introduced, Victoria Prentice's dad. I used to be the MP here in South Northants and still live and have done for 50 years at Ainhoe, accompanied by my wife, who was Vice Chair of Brackley College Hospital Trust for the whole of its duration. First of all, I'd just like to make it clear, it's very welcome that you come here and take people's advice. And secondly, I am not going to rubbish your objectives or everything you want to be driving at. And of course, if we can get a more economical and a safe or safer service, that I'm very much signed up to. And particular bits, let me concede, for example, stroke care, from what I know, that seems to me absolutely along the right lines. But could I just raise two issues which are specifically about maternity, and one which in a way is implied because it's part of the general Horton issue, I think. First one on maternity is this question of low-risk patients. I think with the withdrawal of the consultants, the numbers who were judged to be safe, low-risk patients, for midwife delivery in Banbury dropped quite low, and I'd like to have some feel for the percentage who would be able to have their babies in the Horton as against being transferred to Oxford, with particular reference, for example, to epidurals, which I think may be difficult. Secondly, on the question of transfer in an emergency, and all our 3 children, including our daughter, the daughter that we mentioned, were born in the Horton. I can remember actually rising from the television programme, getting my wife in the car and being in the Horton in 10 minutes from Ano. That's what you do. Now, going to Oxford, particularly at busy times, is more difficult. So transport is relevant to that. And then 2 more general questions. Huge expansion in the area. I think your own statistics suggest a 5th extra population over the next 10 years. How do you cope with the facilities, whatever? It's no good transferring to something which is not up to the job of actually receiving patients. And the final point is the interrelation with the accident and emergency services, because, as you know, there's always a concern in Banbury and Brackley about the critical mass of the Horton, that it's providing sufficient services to be able to be, in a sense, recognisably a district hospital. There will be things that we can't do there, but we want to make sure that we can do as much as we possibly can in the interests of patients. Thank you.
All right. Thank you very much indeed. So just summarising there, happy or supportive of some of the things for the stroke side of things. Questions, obviously, about maternity, transport, population. Shall we start off with probably the transport and population one first? David?
Thank you for those questions. We'll do our best to answer those. So I think we are aware of the issue about transport, and we've got some data which we have shared, and we'll put more of this on the website in terms of that people have got, what the travel times that we're working to here. They've been provided to us by the South Coast Ambulance Service, so that's where we have got the data from. But we will put more of that data on our website, because it is a question that's been raised in a number of meetings, so very happy to share that. On the issue of the population growth, again, I'm certainly aware of that in the Banbury area, in the other parts of the northern part of the county. I think the issue we have, and colleagues will talk particularly around the maternity, we are taking account of the projected growth in the population that we have. I think some of the issues we have, though, that doesn't necessarily mean just because the population is increasing that therefore we can continue to do everything that we have been doing at the Horton. And I think as you recognise and as I think also as Joe said, some of the way medicine is being practised these days is changing. And I think we have to respond to that. So there are some specific issues we'll come back to. So if colleagues say something around the maternity, and then happy to come back to any of that. So thank you for that.
Dr. Kieran Collinson. Now, Kieran is a GP in West Oxfordshire, but is also the lead for maternity in this particular transformation programme.
Yeah, thank you for that question. I think they're really important ones to answer. So just to give you go back to the beginning and give you some background. So we're looking to really redesign in a way that the whole antenatal pathway, so not just where people give birth, but right from the beginning. So when people first come to their GP when they're pregnant, that's when we're looking to start to make changes. So it's really about having a really thorough assessment of somebody's risk right from the start, and trying to figure out who's potentially a high-risk pregnancy and who's got a low-risk pregnancy, and then making decisions on where they can give birth safely best according to that. Now, obviously, risk can change as the pregnancy progresses, and that needs to be assessed as the process continues, so that needs to be looked at throughout. Once you've got towards the end of the pregnancy and you want to make your choice as to where you want to deliver, that's when you need to decide, according to your risk, where the safest place will be. Now, we want to have, as many choices as possible for women, and that could be a home birth, it could be a midwife-led unit, or it could be an obstetric unit. So then you need to decide which one you want of those based on the medical facts really about safety. Now, we know there have been studies done that have shown that probably about a third of women will be assessed as being low risk. So those women, it would be very good. It's shown that national evidence has shown that an MLU, a midwife-led unit, is actually a really good place to give birth. And the reason for that is that the outcomes for both baby and mum are very, very good. So the outcomes of the baby, because obviously people have a real concern about what's going to happen to their baby, are just as good as in an MLU for those low-risk women as it would be for an obstetric unit. But the outcomes for the mum are actually even better than if it was an obstetric unit, because they're less likely to have interventions like a caesarean or being induced or having instrumental delivery. So we know that an MLU is a really good option. So the question then is, well, what about the other women who aren't low risk? Well, the high-risk women, they already need to be seen in a specialist centre to get specialist input. So they may be women who've got, say, diabetes or other health concerns. So those women will be best having their babies at an obstetric unit. You then got the women sort of in the middle who you don't know. So they may appear to be low risk, then they arrive at the MLU and actually something potentially could go wrong. And that's the people that you're alluding to. And that is the people that most people would worry about because it's unpredictable. Now, we know that pregnancy is not a no-risk situation. That's just the nature of pregnancy, unfortunately. So it's how do we manage those risks in the best possible way. So if a woman decides to go to an MLU because they're a low-risk pregnancy, something goes wrong, we need to know that that woman can be managed most effectively. So if something did potentially go wrong, she may need to be transferred to an obstetric unit. So any MLU already has processes in place to be able to transfer women in that way. We've got MLUs all the way around Oxfordshire, and we know that women are transferred to the obstetric unit in line with what other obstetric units and MLUs do as well. So national data says that about 25% to 40% of women in an MLU will need to be transferred to an obstetric unit. And that's not just Oxfordshire or around here, it's the whole of the country. And that's the type of levels we're looking at in Oxfordshire as well. We're in line with that national data. So if a woman from here decided to go to the Horton and it was then deemed she suddenly became high risk in that pregnancy, she would need to be transferred to an obstetric unit. And we need to have the processes in place to ensure that she's transferred quickly and safely. And those are the processes that we're really looking at. So looking at, how long it takes and the processes between the midwives establishing that there is a risk and getting in contact with the ambulance and getting that woman transferred as quickly as possible. And we're certainly not underestimating that part of the process. That's probably one of the most critical parts of the entire pathway.
And I know you did explain it, MLU, midwifery...
midwife-led unit.
Right, okay.
Yeah, I mean, just to finish up on the last question about the interdependency with emergency department, we don't believe that the change in the arrangements for maternity would materially affect our ability to sustain an ED department, and indeed we're already doing so at the moment successfully. So we believe that could continue.
ED department.
Sorry, emergency department.
That's right. No, I'm just aware that there are so many acronyms flinging around. Okay, there was a hand sort of back right, I felt, earlier on, I think. Yes.
Hi, thanks. Excuse me. Hi, I'm Liz Siggs. I'll put my hand up. I currently work for the Trust. I'm biomedical scientist at the JR. Come April, I will be the laboratory lead at the Horton. My question relates to maternity as well. I live in Brackley and with a vested interest in those services. Why not? We know that the maternity services at the Horton lost their training status because of the diversity of different clinical cases they were seeing. Why not, as happens in many, many other disciplines with the laboratories in nursing, primarily employ those people, those doctors in Oxford, where they can maintain their training and rotate them out on a rotational basis out to the Horton so that you have the obstetric care there, and then so they are on a rotational basis.
All right, Liz, I think. Thank you very much. Yep. Catherine Stoddart.
Thanks very much for that question. One of the key issues around that rotation, which we will take back as feedback, and we've had this feedback from many people, is that because it's not a training place, we can't rotate those trainees into it, even when they are actually at the JR. This is not a decision that is made by the Trust. It's undertaken by Health Education England and the Deanery, who provide training places for our obstetric trainees. And their decision several years ago originally was to to not make available traineeships, but the trainee places. But we have been able to maintain it over a period of time through a partnership with the university, where some of our clinical research fellows have been working part-time, I guess, in their roles up at the Horton. That is no longer sustainable, partly because they're not available. There's a 25% shortage nationally in trainees for obstetric places. So we're not dissimilar to the rest of the country. And we are not able to put trainees in a place where there's not the trainee position, unfortunately, because we have considered it and we'll take any ideas on board if you have others, but we can't do that.
And the decision of whether it's a training place or not is made by...
It's made via Health Education England and with the deanery. Yeah.
Further questions, please. Yes, there's a lady second row here. If we just wait for the microphone. And it's a lady in a dark coat.
My name's Anne Smith from Helmden. I'm concerned about the fact that we live in Northamptonshire. John Radcliffe is Oxfordshire. I have a friend who is very seriously ill. She was transferred from Banbury to Oxford, and I was actually visiting her when a lady came in and said, I've been all morning making numerous phone calls to get a care package sorted out for you so you can go home. But she said the problem is sorting it out between Oxfordshire and Northamptonshire. The only option for you is either you go up to a ward upstairs where there are about 40 people in similar circumstances to you waiting for care to be sorted, or you go home and arrange private care, and eventually we might be able to reimburse you some of the money. So she's actually come home, but is very worried about the cost of her care. And so it really concerns me that I live in Northamptonshire.
All right, thank you very much, Anne. So on that question of, as it were, cross-border cooperation, Andrew Stollard.
If I kick off and then hand over to David, I could understand that from a patient's point of view, administrative and geographical boundaries are meaningless. From a trust point of view, we consider the population of South Northampton and South Warwickshire to be part of the core catchment population of the Horton, and we have a responsibility for you to look after you. Some of those services, however, are run by different organisations, and that's part of the problems that we are trying to overcome with, for example, the integrated hub that you heard about there, to get much better, this is jargon, but seamless care, so that the patient doesn't see these handoffs between one organisation and another. And it is absolutely true to say that it is more difficult to organise some of those onward movements for patients from one organisation to another when those patients are outside of Oxfordshire. And we are working very hard with our colleagues and getting help from the CCG to improve liaison between the organisations such as ourselves and organisations in the neighbouring counties. But as I say, from our point of view as a hospital, this population that we are in today is absolutely part of the core catchment population that we have a responsibility for, and there's a duty on us to work harder to try and make sure that those difficulties that your friend experienced are overcome and are less intrusive than they are. David, I don't know whether you want to say anything.
And probably just to pick up, I think, the issue around social care, because we're here as the people responsible for the health service, but when we talk about social care, it's either, as you know, these are means-tested benefits, social care being provided by county council. So part of the issue in this area is Northamptonshire County Council. We're talking about Oxfordshire County Council. It is pretty clear to us, and I think we've heard it loud and clear through other meetings as well, that the health service has to do far better to be working with social care. I think if you're a patient, if you're on the end of this, it really doesn't make any difference. So but these boundaries get in the way. So we need to take away, and we will do. How do we get a much better joining up of health and social care? Firstly, and secondly, the other issue that we need to pick up is to talk to our colleagues who are responsible for the health services in Brackley, and some of that is with NEAN CCG, which is the CCG in Northamptonshire. We've had some dialogue there. I think we are conscious that we need to do more to engage with the other CCG around that, and we will take that on board. That's part of the reasons why we were very clear we did want to have a meeting in Brackley, and we've got a second one. Before that second one, we will have a series of conversations with our colleagues. But thank you for making those points.
Sure.
Let's come in as well. Yeah, I mean, thank you, and it is a great source of worry to people about care at home, particularly after hospital, and we've heard it quite a lot, as David said, going across the county so far. One of the things as a commissioning group we're quite keen on is trying to integrate health and social care much better, so that you actually try and produce much more of a one service effectively. One of the things we realised we were going to have to do if there remains a big gap in social care is do much more through the health service in supporting people at home who have been in hospital who may go in hospital. So a big part of the plans are actually to expand the amount of nurses and care workers who can support people after discharge, and that shouldn't depend on where you live. So that should be there for your needs rather than your location.
Mm. And it's difficult, obviously, for any panel member to discuss any particular patient, but I'm sure everyone wishes your friend all the best. There's a lady who keeps her hand up. It was very good. You don't need to keep your hand up. Once it's gone up, I'll try and look at it and get there. But there's a very patient young lady who's got her back to one of the pillars, as it were. Yes.
My name's Charlie. I've lived in Brackley all my life. I had a post-bleed tonsillectomy in September. I was told to phone an ambulance by my GP. However, we cover Northamptonshire, which is East Midlands. Obviously, have they been consulted about the transport time and going to Oxford? Also, they have to cover areas as far as Corby, and we were actually told we would have to wait up to an hour for an emergency ambulance to take me, who was bleeding, to the JR, because they are the only emergency ENT surgeons that were closer to me, and that's where I had my operation. I got in the car and took myself, potentially could have bled en route. This was in the middle of the day, and it still took me 40 minutes. Have you consulted with the surrounding transport services, i.e. Warwickshire, so West Midlands, because Coventry go to Banbury as well, and East Midlands, which is Northamptonshire?
All right, so a transport question. Thank you very much. Let's start off. Andrew.
So the short answer is yes. So we are in consultation. The CCG and ourselves are in consultation with all the neighbouring ambulance services. I'm sorry to hear of your own experience. That is not acceptable. The situation will be that the ambulance service that pick you up will assess your clinical need and take you to the nearest appropriate hospital. So, as I say, I don't understand what happened in your own particular circumstances, but that would be the situation. And so, yes, we are consulting, and nothing that is being proposed within these consultations would actually change that situation at all.
Yeah, again, I think really sorry to hear about your experience. I think it's worth just, if we can, at the end, someone taking your details so we can feed that back, because some of the cross-border ambulance service work, it can sometimes go wrong, so we do need to take the feedback so we can feed that back to the different services.
Yeah, I'm very happy to pick that individual up with the individual. I'm sorry if you can't see me, I'm stuck in the corner here.
But so there are postcards and stuff, so if you want to write all that down or come and meet Sula afterwards, then that's great. Okay. Other questions? Right, now we've got quite a few. Let's the gentleman on this. Sorry, I'm making it very hard work for you to reach people on the edge of... Can people not at the age ask questions? Here's the gentleman here by the pillar again.
Thank you very much. My name's Jeff Wilkins. I'm a Brackley resident. For the last 14 years, I've been battling cancer. And in that time, I've been through chemotherapy 7 times and had 2 stem cell transplants at Oxford. A lot of my treatment was done at Banbury. Excellent treatment, always made to feel, as an individual, treated exceptionally well. I've had stem cell transplants and some chemo at Oxford. Oxford is a very bigger unit, but I've had good treatment. But at a big unit like that, you're made just to feel like a number on a conveyor belt. And you don't get that personalised treatment you get in a small unit, such as Banbury. On top of that, for the last 12 months, I've been having to travel to the Churchill Hospital on a fortnightly basis for checkups. And on the transport issue, I go by my own transport, but on some occasions I can sail through from Brackley to the Churchill in 45 minutes. A good third of the occasions over the last 12 months, it's taken me over 2 hours with transport issues, and then once we get there, I've had to bail out of the car to get to my appointment while my wife sits in the car waiting to try and get parking, because the parking situation is so diabolical at Oxford. I have spoken to clinical staff at Oxford. they're all horrified that Banbury may be reduced, and they just, according to talking to their own colleagues, they don't know how Oxford will actually cope if they have to take many more from the Banbury area. So they're my issues. Thank you.
All right, thank you very much. First of all, can I say you look remarkably well after all you've been through. Let's start off Andrew Stevens, rather.
If I start off with some of that, and then I'll hand over to Catherine. Thank you for your praise of the service at the Horton. I want to make it perfectly clear that under these proposals, chemotherapy will expand. In fact, if we're looking at it roughly, we are planning to double the amount of chemotherapy that is done locally at the Horton compared to today. So we understand, and particularly with a disease such as that avoiding the need to travel is absolutely imperative and is part of your good care. And so we are seeking to double the number of patients who could receive chemotherapy locally. We do recognise the problems with transport. It's probably one of our number one issues as a trust at the moment in terms of access to the sites in Oxford. And again, these problems are precisely the sort of issues that we're trying to address through the plans. Under these plans, it is true that up to, say, 1,500 patients, so that's 4 or 5 a day, would have to travel down to Oxford, who currently aren't. But under the plans for planned care, 90,000 patients wouldn't have to travel. So that's 250 to 300 journeys a day that would be saved. So you can see that the net saving in journeys to Oxford for patients from this part of the county would be reduced very, very significantly. That will help us with some of our congestion. We are taking further steps. We're in consultation with the council around what we can do to improve parking and access, both by ourselves, taking some short-term action, but we've also joined forces with the 2 universities and with Oxford Health, who run services on the Warnford site in Oxford, to say, right, how can we combine to improve public transport considerably for those areas in the Horton where health facilities and the academic facilities. So we're absolutely committed, A, to expanding services dramatically at the Horton for the sorts of services that you've been receiving, but also to address the parking problems and the access problems at Oxford. And again, that's a key objective of these sets of proposals. Catherine, I don't know whether you want to add anything.
Where are all these extra people going to park in Banbury?
So that is a really good question. I'm really sorry that I jumped in, though, and said I'd answer it. So part of our plans, just to take a little bit of a step back, we have already increased the size of the endoscopy suite at the Horton. We've been looking at expanding renal dialysis, and chemotherapy are key planks for us because those groups of patients have to travel a lot regularly in order to get to be seen. And we do know that parking is an issue, as you say. As part of the plans, the actual physical plans of building additional capacity at Banbury, we will include car parking. We recognise that it's a huge problem. Nearly 300 people a day, appointments a day will be reduced at the JR and at the Churchill. That's fantastic for those people that have to visit there. For those people at the Horton, you can imagine that we need to build some multi-storey car park, of course, in order to improve that.
OK, and so just to be clear, Andrew, I know you can't talk about a specific patient, but in theory, somebody in this gentleman's position, if he were treated like that in future, would actually be treated more at the Horton than was currently.
Yes, as I say, we're looking to double that.
OK.
I should add something as well.
Yes, Dr. Joe McManus.
Slightly off-piste as well, because this isn't part of the consultation, but really what we need to be doing is more, which isn't reliant on hospitals as well. So a lot of the time people have to go back for appointments just to get a result. And often you have to go twice, once for the scan, once for the appointment. GPs often not well linked up with hospitals, and we haven't started using telemedicine properly. So all these areas should be used to be able to actually deliver more care in primary care and stop people having to go to the hospital in the first place, which we haven't really talked about, but that has got to be something which we talk about more over the years to come. It's a bit of a sort of a longer term thing, but I think it's quite important people start understanding that and trying to talk about it. And there's a lot the hospital can do in the short term just to reduce follow-ups, the people who don't actually need to go back, that can be dealt with by a telephone call.
OK, there was this lady at the back there. Yes, yes, you, madam, yes.
Thank you. Councillor Sharps, I would just like to say, although it's excellent that the facility is going to move over to Banbury, those that don't, that are still over in Oxford, we have a terrible bus situation in Brackley. So for those that are going to try to get to Oxford via the bus, myself, I've done it. It's almost impossible. I have to go into Banbury, and then I have to go by train, and then I have to take 2 buses, and that can take almost 2 hours. One of the appointments I have to attend, I have to take somebody with me, and then I have to wait. The hospital finds this in a sort of, how can I say, inconvenient. I have tried to do it via the
patient transport.
Patient transport's not allowed to come and sit with me. So there are so many ways it doesn't work. We need a better bus situation here, but also all of these things need to be taken into consideration when you do that. Everybody here should be using the buses to alleviate the problem that you have in Oxford, but we can't because of our buses.
Councillor, thank you very much. Has there been liaison or questions about the bus routes councils? David?
I'm not sure whether they have specifically in this area. I think we know, though, public transport's cropped up through our other meetings. Not everyone drives a car or actually wants to. So the public transport is really important. So again, it's one of the issues. That when we pull all of this to get this information together at the end of consultation, we do need to reflect on that. I think the issue is, and I think it's coming out. It's trying to get that balance between doing as much as we possibly can locally, because that's where we want to do, but there are for some services where they do need to be centralised. And of course the centralisation within the Oxfordshire area will be through the hospitals within the John Radcliffe. And it's trying to get that balance between, on the one hand, local accessibility, but on the other hand, how do we deliver some very specialist services? And I think that's part of the challenge that we're facing.
Okay, are there any written questions that anyone's handed in? Great, so everyone's happy to talk in that case. Okay, there's a gentleman about halfway back there with a shirt 2 in. Yes, please, sir. Thank you.
Thank you. My name's Mark Morell. I'm a town councillor. The issue I've got is about bed population ratios. You mentioned about bed population within the presentation. Also, there's a figure in terms of the percentage use of a bed. When over 85%, it becomes acute problem of cross-infection, and you're talking about hubs. In the high-income countries, the ratio is over 6 beds per 1,000 population. In England, it's 2.73 at the moment. What is the bed population across the Trust? What is the bed population across from the Halton at the moment? And what is the percentage usage? Because it seems to me that we talk about bed blockers. I detest that term because I think that no one wants to be in hospital longer than they should be. I detest the fact that elderly people are declared incontinence because they're in hospital for a period of time. I think a lot of stuff is being hidden. And I know a lot it sits at central government, so I don't blame you for trying to do a very difficult job under circumstances.
All right.
The system isn't working now, so I'd like to know what those ratios are, please.
I was pleased you pointed out, obviously, the panel can't speak about government policy and national statistics and so forth. To be fair, from memory, and I think it'll be on record, I think David said, as have been called bed blockers. It wasn't his particular phrase, but I only point that out early, being a very pedantic journalist. Okay. Andrew.
I'm sorry, I can't give you the bed ratios off the top of my head, but we will provide those. What I would say... So 45 of the beds that we are consulting on now are part of that programme. I would. Yes, I know, and the agreement with the health Overview and Scrutiny Committee, who have oversight, so they're the body that have oversight around consultations, asked us to consult on these as part of this consultation. They recognised that the care that we were providing, that was described in the video that Joe has described, was a positive move, and so they didn't ask us to stop the programme, but were insistent that we came out to consultation now, which is what we're doing. Of the 45 beds that have been closed, we have replaced those, a number of those, with day case beds. And it goes back to some of the comments that Joe was making. Medicine has changed. Increasingly, in the past, we've used numbers of inpatient beds as some form of measure of quality. That's no longer appropriate. There are different ways now of looking after patients. The number of patients we've treated at the Horton has not gone down because of those bed releases. They've actually gone up. The quality of those patients, as far as we're able to tell, and we've been monitoring it very carefully, has also gone up. We looked at those patients who were part of the pilot project that we put out into nursing homes and into other community-based settings, and we've asked them. We've looked at their clinical outcomes. We've also looked at the patient experience. And we've been told that people would rather have their relatives in an area that is not busy. If they no longer need the acute care, they no longer need medical doctors, they no longer need the sort of care that we as a hospital would provide either at the Horton or at the John Radcliffe sites, they would rather be in a more appropriate setting that is less busy, where they can begin to mobilise, get their independence back. So I think looking at beds is outdated now. Medicine has moved on, and we have to find better ways of measuring. The amount of resources within the county has not gone down. All the money that's been saved from those beds has been ploughed back either into beds into the community or into the care hub or into providing additional community-based therapy support, social care support. And it's those measures that we need to look into when we're looking at rather than bed ratios.
Lead nurse Sula Wiltshire.
I think what Andrew has said is absolutely right. The way we look after people now, it is different. In my lifetime, it's changed dramatically. It's really important that people are kept as well as they possibly can be. So what we're trying to do is maintain an individual's wellness. So they may be at an advanced age, but whatever independence they have, to try and maintain that so they keep well as long as they possibly can. The focus also of the consultation is about improving quality and safety. That's absolutely foremost in our mind. Dependency in older people, if they lose their independence, it can be one of the most devastating things. I have a number of older friends who've lost their independence, and it's hugely debilitating, much more so if they're in a hospital scenario, because that makes you rather, if you like, adherent to the rules of the hospital that perhaps you would break when you're at home quite happily. So I think it's really important that we do try and encourage a different model of looking after people.
So to clarify, sometimes... Sorry, sir, hang on a minute. So to clarify, in hospitals sometimes some elderly lose that mobility and never get it back.
Yeah, absolutely. And I've seen that in a number of people.
All right. Dr. Joe McManus.
Yes, I just want to add something, really. I mean, I think it's a very valid point and very valid concern. I think it's quite a difficult thing to have a discussion about. That it, as Andrew said, it isn't about the absolute number of beds. It's about the actual flow through and the pathway through the beds. And what is really critical, and this is a really important thing to remember, it's about the care that people have early on in the community, and also the care that people have at home to help them get out of hospital. So we know that if we invest all the money we've got in beds, but don't invest in care at home, then what will happen is people will be stuck in those beds. It doesn't matter how many beds you have to have hundreds more. That if we haven't got the actual care to get people out of the beds, people will quickly become stuck and the whole system will be blocked up. And that's not what people want. And it's about trying to work out how we get people's care properly in the community to be able to allow people to be seen quickly in hospitals.
Okay, I've nothing against counsellors, but if we can have any questions from non-counsellors, just for a few minutes. Okay, I've got a lady here with a scarf on her, yes, and then I'll come to you next. Thank you.
Susan Lidgley, Helmden. I think our main concern is the downgrading of A&E. Now, in Helmden alone, which is a small village with a population of about 850, we had 8 people admitted to the Horton. 2 needed to go to the JR. There wasn't room at the inn. Now, if you downgrade that even further, where are these people to go? Because there wasn't room in Northampton either. I mean, what are we to do with people that, you know, maybe they hadn't got the expertise, but at least they looked after those people.
All right.
You know, there's also another point. We've had 3 things closed in this area. Culworth Nursing Home closed this month. The Red House was closed. And, of course, we we've lost our cottage hospital, which we were promised a new one of 15 years ago.
All right, I think to be fair to the panel, you're probably talking about another county's thing, particularly with the care home closing. It's not, but we'll take the point. David.
Well, let me start off. So again, this is, as I said earlier, one of the things that we need to do is to talk to the people responsible in this area, and that for a large number of people, that is the NEEN CCG. So we will pick on that. So the community hospital, that was not our decision. We are not part of that. That is with the clinical commissioning group in this part of the area. But I think on the more broader issue, I think it is back to around A&E. So on the A&E, there is nothing in these proposals, that we're not talking about A&E in this first part, but we do need in this first phase. But as I said, there will be a second phase of consultation later in the year. One of the areas we have to address is around the A&E that's provided at Horton. I think we've been very clear on that. We don't know what the answer is yet because we haven't done that. We haven't done the work. And part of what we're picking up through this is certainly the views of people, the concern that local people have here in Banbury and in other areas of the north of the county around the A&E. I think what we need to set out, as we will do, is to say this is the issue we face, as we've done in this consultation. These are the issues we face. These are the options, and to have those discussions. So, but there is nothing in this first phase of consultation around the A&E department at the Horton.
And the second phase will start.
Well, we're doing that work now. The second phase will of formal public consultation. It'll be later than this year. I mean, we are saying probably late autumn is where we've done sufficient work. Given the complexity of what we need to do, that will be later in the autumn when we would do that. And clearly, in the run-up to doing that, we do need to have that level of engagement with local people, with the GPs in this area, and with also the clinical commissioners.
And and again, that engagement would be done in a similar way.
Yes, it will be.
Right. Okay.
Can I just add something as well?
Yes, Dr. Ju.
Because I think the gist of the question as well is a worry that when you're unwell, the Horton facilities won't be there for you. And I think that's really important just to bear in mind. And I think certainly I work a lot with our local GP colleagues around Banbury, and they all say the same thing as well. So what they'll want is the Horton to have a decent standard of care, so that if somebody's unwell, you can go to the Horton and you get your treatment. So a lot of medical problems such as pneumonia, chest infection, confusion, you need to have the right facilities, the right diagnosis at the Horton, so you can be seen properly and then discharged if needed. So it's I think a lot of clinical colleagues would share that concern.
All right, I promised a couple of other people first. There was a lady in a white jumper with black stripes just on the aisle here. Oh, I'm sorry, because of the speaker. I'll come to you after that as well then. But the lady there. Oh, was your question for her, as it were? No, okay, far away.
It's quite a simple question. I'm Sheila Robbins. I'm a car service driver, and I'm frequently going up and down to Oxford for injections in elderly people's eyes. I'm aware that you've got most of the eye centres in Banbury that you go for the normal test, but it's the injection that they seem to go for, and I'm sort of taking a 90-year-old on quite a vast journey just for an injection, which I don't want to put the injections down, but it's a long way to go.
You're sounding like you're giving them as well, which is multi-skilling to a new level. OK, well, I'm sure that the panel will be keen to do this one. Catherine Stoddart.
So that is a really good example of the type of services we would want to be doing at Banbury, for example. It's not a simple... I wouldn't like to say it's a simple procedure because I don't think I could do it, but it's actually... quite frequent, it affects a lot of people, and it can be done in a different environment. So when we talk about a diagnostic, therapeutic and outpatient centre, we're talking about those kinds of things, day cases, procedures that people have regularly and that are relatively low risk but need to be done, and that is a fantastic example of what we want to do.
And thank you very much to Sheila. Just to say thank you to Sheila, because obviously support from the community is hugely important, so thank you for what you do already.
Sorry, hang on, let's get a microphone to you so we can hear.
I know I'm elderly myself, but most of the patients that I take in for this injection are over 90 years old.
Yeah.
And I think
Absolutely.
that kind of, yes, reinforces about nearer to home and so forth. I'm terribly sorry. There's a lady, a red and white striped jumper, who apparently I haven't seen, so I apologise.
Hello, my name is Dr. Fiona Mason. I'm a retired GP from Northampton. Nobody likes change unless they're the ones driving it. It's a well-known fact. But there is positive change and negative change. I would like to thank the panel for their presentations on the positive change. So we are hopefully getting more imaging in the Horton. As I understand it, it's going to be the Oxfordshire Centre for Hernias, is that right?
Well, there will be hernias.
Yep.
Yeah.
Okay, but I would like to focus on maternity services. Now, the examples of the imaging and the hernias are not time critical. But everybody here, I'm sure, will agree that maternity services are very time critical when things go wrong. It is not the purpose to discuss the politics, unfortunately, here of difficulty recruiting and maintaining O&G registrars. However, the information we've been given today is there is a 25% reduction in recruitment. So by flooding the JR with Horton people, the 25% is going to be even more under stress at the JR. I'm going to ask Dr. McManus, you used a really interesting word, Dr. McManus, a temporary removal of doctor-led services from the autumn. There was, at one stage, there was supported training status in Banbury, but there were two critical incidents that led to the Royal College removing training status. So what happened? Knee-jerk reaction. The training status was withdrawn. Quality O&G middle grade doctors, who are the ones who run most of the maternity services, were taken away. The word temporary, Dr. McManus, do we have any hope as Brackley residents that there will be a doctor-led midwifery service returned to the Horton?
All right. Thank you very much indeed. The first part of your question, I caught Andrew's eye.
If I deal with just some of the factual issues and then perhaps hand it over to Kieran around the clinical issues. The 25% that was referred to training places, so middle grade training places. So these are places in the Thames Valley area and across the south that are accredited for training. There is a 25% vacancy in those posts. What we are talking about are posts that aren't training accredited at the Horton. So the vacancy rate for those is even greater. And indeed, the Royal College of Obstetrics and Gynaecology in a recent report suggested that no unit should be seeking to maintain obstetric-led care with non-training grade posts because they are hard to recruit and there are a range of other problems. So that 25% is for training accredited posts. The other issue to say is that the training accreditation was taken away from the Horton in 2012 purely on the basis of numbers. Nationally, the number of training posts was reduced, and so the deanery locally had to decide where those training places should be allocated. They decided that because the Horton was delivering so few births, and as you heard Veronica Miller, our consultant obstetrician, say on the video, the range of experience that doctors could get in training was so limited that they would not get adequate treatment. So for those reasons, the training posts at the Horton had their accreditation taken away from us, and those training posts were allocated to other bigger units in the area. And so it was then that we managed to keep the service going for a short while by having this arrangement with the university.
And can I just ask, because it's come up a couple of times, the deanery. Who are the deanery? Am I alone?
Yeah. So the deanery are part of the organisation that run training for doctors, and for them, the key points that the key objectives they have is to make sure that the doctors that are being trained now are capable of providing safe, adequate care when they qualify.
And the deanery is based in London?
No, each region has a deanery, so we're in the Oxford deanery.
Okay, great.
Catherine.
Just to add to that, during this period of time, I wouldn't want you to think we hadn't been trying to recruit. We have been trying to recruit in a whole range of ways. Part of it has been about making, I guess, explicit some of the financial benefits and the ways in which we can actually encourage people to apply. It's really hard to get people to do that. At the moment, we have 5 trainees, but we do need a full rota of 9, as you can imagine. We need to have it running 24 hours a day, because the risk we have is if high-risk women attend the Horton and they think they are going to be attended by an obstetrician and there's not an obstetrician there, that is a greater risk than being able to tell them very early on in their pregnancy where the most appropriate place to give birth is.
Absolutely. Yeah, so I'm just...
assuming that there is a possibility that maternity full services will return.
So just sorry to confuse things. At the start, that was the presentation, and the temporary refers to what the hospital had to do last autumn, which was to close the obstetric-led unit and turn it into a midwifery-led unit on a temporary basis. This consultation is about actually what we do longer term, and the proposal that we've got is to make that a permanent state of affairs. So sorry to confuse things, but the temporary nature was effectively the emergency application that the trust had to do because of the lack of doctors at the time, and this is about a discussion about the longer term prospects.
Now there's a gentleman right at the back on the right in a black jumper there with glasses. Yes, please.
Hello, my name's John Watts. I live in King Sutton. I've got a question about some of the specifics of the consultation itself. Early on in the consultation, we're invited to agree or disagree with a series of statements, and these include a hospital bed is often not the best place for frail elderly people, and people want to be treated close to home where appropriate. These statements seem quite obvious to the extent that it would be very hard to see anyone disagreeing with them. Could the panel say something about what the purpose is of inviting us to agree or disagree with such obvious statements? And the second part of my question is, it was mentioned earlier that the consultation includes the future of 45 beds that have already been closed. To what extent is this a meaningful consultation, and can we really, in a meaningful way, change and affect your plans in the responses we give, or is this a done deal?
All right, thank you very much. I think both those bits kind of refer to the main hub of the question, which is about the consultation, and is the panel listening as such? Chief Exec, David.
Yes, let me try and answer that. So on the first one about care close to home, why are we asking that? Because we're saying that should be one of our building blocks for how we build services going forward. It should be around, as much as we can, provided that care closer to people's homes, and if people don't need to go into hospital, they shouldn't do that. The reason for asking that is then it's the consequence of doing that, because if you move into that model, so it's much more about care close to home, more prevention, then actually the consequence is around needing to make changes within our hospital services, and that leads then into why we believe we need fewer hospital beds. So it's really important we do get the views from the public on that. In terms of are you going to be listened to, so as we put up at the start, we're running 15 of these public meetings. We're doing, people can respond to us via the website. So there's a lot of stuff that we're picking up. The process is at the end of the consultation, the clinical commissioning board, the clinical commissioning group board will need to make a decision. And then we have to balance up the proposals that we put out there with the views we're getting from the public. People have said to us, well, you're not giving us any options. So if we all say, no, we don't agree with this, then what happens? Well, we need to take on board that. But at the end of the day, we have to make a decision, and we have to balance up issues around providing the best care, best quality we can provide within the resources available. And that's part of why it's really important that we do hear what's going on. And also for people to say, well, actually, as I think one or two people have said this morning, why can't you provide the services in a different way? So, if there are views around, well, this is what could be done differently to not to make these changes, it's appropriate for us as a board to actually listen to those.
Dr. Joe McManus.
Yes, so in a similar vein to David, I think we are listening, and one of the reasons why we're coming out is because there will be quite a lot of complexity in some of these proposals, and there will be ways that we can improve them. I mean, the reason why, and I understand completely why people will feel a bit sort of cross about the fact that there's only one option for most of these. The reason why that is the case is because people have racked their brains to try and think of alternatives. If people have alternatives, then we would listen to that. But we have to move forward in the best way we think is fit. So what we're trying to do is be fairly open about what that is, and actually say to you, well, this is what we think has to happen. And if there are alternatives, we will listen to that. Just, I guess, on the specific of the hospital beds, I mean, there's always going to be the potential of opening more hospital beds. The problem is they cost a lot of money. So if we were in a situation where we needed more, then they could be open more. But the problem we would then have is how do we best use our resources in a limited situation? And what that would inevitably mean, there'd be less money for us to be able to support people at home and support people in the quick turnover of diagnostics and assessment. So I think it's really important that people should sort of understand what the dilemmas are, so at least we've got some sort of shared understanding of that.
Okay, we've got just under half an hour left. I've got to leave a little bit of time for the panel to wrap up, but we are sort of getting through this. I know the Banbury Guardian, Roseanne, wants to ask a question. I'm just trying to steer away from local authorities and things at the moment, but I will come to you if I can. There's a very patient... is it a lady at the back row virtually there? Yes.
Hi, just to go back to the maternity, I've got 3 children, which I had all at the Horton. They were amazing in every individual case. The last one I had was in August, so 2 months before it went into the temporary midwife-led. Each time that I've had these children, all of the the delivery rooms have been full, and especially in August I had to wait in a side room, a waiting room, whilst in labour before a bed became available. So you're talking about transferring these women to Oxford or surrounding hospitals, and there not being enough women delivering at the Horton to keep it viable. But is there actually enough? Have you worked out whether enough women could deliver it at the Horton to make it viable? And when you talk about changing it to a midwife-led unit, that you apparently in your brochure you put that it's going to be, you're going to make a new unit, you're going to build a new unit. Why can't you improve on what is already there? And where is the space? Are you improving the John Radcliffe maternity unit to cater for these 1,400 extra women?
All right. Thank you very much indeed. So it's sort of two-part question, a little bit there. A little bit about has any effort been made to get more women into labour, as it were, at the Horton? Catherine Stoddard.
It's an option. One of the key things, of course, is around choice for women. And so we do have, in the same way that Banbury women may choose to give birth, particularly in midwifery-led unit in Banbury, women in Oxfordshire or any of the other surrounding MLUs choose to give birth there. So although that is a possibility, it isn't actually, the numbers don't stack up. And I'd have to say at 1,250 births, which is around what happened at the Horton in the previous year, that's not close to what there'd have to be an awful lot of births move in order to make it sustainable in the way that we think would be attractive for training places, for example. The other question is about the capacity at the Horton. There is capacity, and particularly with the number of midwives there, for more births at the Horton for low-risk women. So that is a great opportunity. And certainly as we start to look at the rebuild of whatever comes out of any of the consultation and some of the new services that might go to the Horton, there's an opportunity to improve on that. We have increased the capacity at the JR in order to cater for any additional women. That included some rethinking of the way that we used our delivery suites so that we actually have more available, and some infrastructure changes that we made in order to do that. So we do have the capacity to provide for the additional women at the JR. Of course, women from this area are also making choices about whether they go to a different hospital local to you.
Dr. Kieran Collins.
Yeah, and just one final point, just to add to that.
For example, South Warwickshire or Northampton Hospital, people are choosing it.
Well, The choice is there, I think, is the choice is there.
Yeah.
Okay.
So just to add to that, so if we were going to make it viable at the Horton, like Catherine just said, you'd have to increase the number of births significantly, like really huge amounts. The Royal College of Obstetricians and Gynecologists have said that any unit that delivers less than 2,500 births per year isn't actually viable to have a consultant-led service there. So we're not just going out on a limb and just making up our own rules. We are going according to national guidance as well. So although I can totally appreciate these are complex things and it's a difficult decision to make, we aren't going a bit rogue. We are really trying to take in all the factors into consideration and sticking with national guidance as well.
So the current figures are less than half. Is that right? What would
yes,
be
about
half?
roughly.
All right. Now, I did see... I tell you what, because I fear I'm ignoring the people to the side. There's a lady here in a greenish turquoise scarf and a maroon top.
You're saying that recruitment is hard to get in Oxford, but with the thousands of houses that are being built outside Oxford at the moment, surely recruitment would be easier in Banbury, where the properties are cheaper. There would be thousands more pregnant mothers in these new houses, and there will be thousands more cars on the road heading to the JR, which is going to make our 40 minutes much nearer an hour and a half. I'm not quite sure how many thousands of houses, but that is not an exaggeration between Banbury, Brackley and the surrounding villages.
Okay. David, has the population growth been factored in, or estimates of population growth in the area been factored in?
So simple answer is yes, it has been factored in. The difficulty we face, and I think it comes back to even with the population growth and more house building, will there be enough births at the Horton? And the answer is, on the data we have, no. There will not be. The issue that the Trust has had, and I think it's cropped up a number of times, I just want to pick up, and what's really important is the staffing and the recruitment. The Trust, to run the maternity unit at the Horton, the Trust needs 9 junior doctors to run the rota in order that it is therefore safe for mothers to deliver in that obstetric unit. The Trust has been unable to recruit those doctors, and Catherine can explain what the Trust has been doing. To get anywhere near the number, so the Royal Colleges talk around somewhere around 2,500 births should be the minimum number. To get to that, we would have to say to a much larger catchment area, and it's not just Banbury and it's Bicester and it's parts of North Oxfordshire. Actually, you can't have a choice. You have to go to the Horton, and that would be directly in conflict with giving mothers a choice. Even with that, the Trust cannot recruit doctors because these posts are not accredited. So that is why firstly the Trust had to make the temporary closure to the unit, and why we are consulting on a permanent change. It's a difficult one. It's cropped up in all the other meetings, and we know how sensitive this is as an issue. But we cannot provide a safe obstetric service if we have not got junior doctors to do that.
Okay. Right, now, we've got not long left. I wonder if I could just maybe get 2 or 3 quick questions together. There's a lady, yes, 2 back from the end there, with a black and white striped top by the look of it. If you can keep the answers really short, we'll try and do 3 or 4 quick ones.
Yeah, hi, my name's Wendy Cohn. What I'd like to ask is, I've heard, I don't know if there's any truth in it, but with regard to recruitment in the hospital, is it true that staff have to be prepared to work either Banbury or Oxford? They have to be prepared to travel between the 2 sites. They're not employed just precisely at Banbury or at Oxford.
All right, so a travel one. There was. What I'll do is I'll get 3 quick ones and then get 3 quick answers. Was there another hand up just in front? There's a gentleman there in the jumper, please.
Thank you. My name's Graham Raven, recently moved to Middleton Cheney. From Chipping Norton, where I know there's other contentious issues, but is there a time scale for the super diagnostics at Banbury? Because it seems to me the whole system depends on good diagnostics, rapid throughput through the specialist hospitals, and then discharge into outside care. who is responsible for building these care homes that you seem to assume exist? And what's the timescale for that? Does it match your plans, please?
All right, that's two. And Roseanne as well from the Banbury Garden.
Yeah, hi. Yes, very quickly. In the BOB STP, it made a very clear point that the acute services at the Horton General were going to be consulted on as one sensible consultation. Why is that not happening?
Okay, BOB SOP?
Yeah, that's the... sorry, it's the Buckinghamshire, Oxfordshire and Berkshire West Sustainability and Transformation Plan, of which this whole Oxfordshire Transformation Plan is a vital part.
Lovely, thank you. It's just so we all know what we're talking about. Okay, so three quick things. Will staff have to be either at Oxford or at Banbury? The timescale for Horton, and then the last question as well from Roseanne. Who wants to go first?
I'll go to the first one. So when we recruit people, we do recruit them to the trust rather than an individual site. However, for medical staff, because they are generally linked to training places, it's to an individual site. If that answers that question.
Yes.
So timescales on the diagnostic and outpatient centre. We're already doing some preliminary planning on that. The actual timescales cannot be firmed up, obviously, until after the consultation has finished. What I would say, however, is we are looking to do things early and bring things forward. So, for example, next month we will be opening a new state-of-the-art CT scanner at the Horton, a multi-million-pound investment, and that will enable us to do far more CT scanning than we can currently do on the very old machine. So those patients who are currently being sent down to Oxford for some of the more sophisticated CT scanning will be able to be done at the Horton as from next month. We're also in discussions with the independent treatment sector, Ramsey, whose building is on the Horton site, where they may have some spare capacity, and we're exploring with them and the CCG the ability to beginning to move some of those 90,000 patients up as soon as we possibly can.
And lastly, the question from the Banbury Guardian about why two-phase.
Okay, so if I come back to that again, it's cropped up in a number of these meetings. Firstly, because we'd had a conversation with the Overview and Scrutiny Committee of the County Council. They're the body that scrutinises these sort of plans, and they said to us they did expect us to go out to consultation on some of the changes. That's part of the reason why we're doing that. But the other part of the reason, it's back to some of the clinical issues we have here, where we do believe we do need to make changes around stroke and critical care. And then on the obstetrics, the temporary closure, it went into effect from the 1st of October. We believe it is right for us to come out and talk to the public and say there is an issue here. We believe that we should make that as a permanent change, and we think it is right, therefore, for us to consult and to consult now on that change, rather than leaving this unit as a sort of temporary, with all the sort of ramifications that have, leaving it effectively as a temporary closure until we consult on everything else, which would probably be over a year. And I think that, and that puts the whole unit and the population in a very difficult position, because we haven't got to a position of making a formal decision. So it's for those, it's not just one reason, it's for those, I think there's three reasons there as to why we believe it is right for us to consult.
All right.
And to consult now. No, we weren't.
Asked to do the acute services at Horton in one go.
Okay, so what Roseanne is saying, because she doesn't have the thing, is you're saying that David was told to do it in one go. David?
Well, I mean, to be very clear, and you'll know this, but I think others won't, but certainly we were not told by what's called the Buckinghamshire, Oxfordshire, West Berkshire Sustainability Plan to do this all in one go, because actually I'm the STP leader, so I know exactly what we were said we should do.
All right, well, for everyone else, it's a bit difficult to get into. Okay, I think it's probably now about time to ask the panel members to sum up some of the points that they've taken on from today, and then I'll just run through a few pointers right at the end of the meeting. But thank you for those questions, and for those I didn't get to, I'm sorry. Let's start off. I think that, Andrew, you want to do a brief summing up. Andrew Stevens, then, from the Oxfordshire University NHS Foundation Hospital Trust.
I suppose, firstly, to say thank you. I mean, these meetings are incredibly valuable. I think I'm taking away three key messages. I think one is this cross-boundary issue. I mean, it's a technicality if you're a patient. You don't want it to get in the way, but it clearly is on time. So I think there is added onus on us, the CCG, the Clinical Commissioning Group, and other groups to go away and make sure that those administered boundaries aren't getting in the way of good patient care. I think the second one that reinforces messages we've heard elsewhere around the county reflects the rural nature of this county, and that transport has to be looked at in the round. So again, I think we need to make sure we're consulting with our county council, our local authority partners who have control over transport policy, to making sure that we're joined up in our plans. And I suppose the third is just hearing the issues that I expressed earlier on, that people from this part of the world do see the Horton as their local hospital, and we as a trust, together with the CCG, need to be conscious of that and continuing to act along those lines. And that's very much why we are seeking to bring more services up to the Horton.
And GP Dr. Kieran Collison.
Yeah, so I know maternity is obviously a very contentious issue, and I want to try and be at least partly reassuring that we have already considered a lot of the points that you've brought up, but I'm very grateful to you for all the other points that you have mentioned. And as I just said before, just to reiterate, it really is about assessing women as high risk, low risk, and finding the right path for them. And if it does go wrong, because these things unfortunately do go wrong, how we can manage those patients best. And the things I've heard as well, like Andrew's also said, is about transport and then the capacity at both the Horton and at the JR to make sure that we've got enough capacity for all those women who go there.
Dr. Joe McManus, GP.
Yeah, again, thank you, everybody, for coming along and contributing. So I've heard quite a lot of really good feedback. It's clear that a big concern is to make sure that Horton is there for you if you're unwell, and it's properly resourced and it's properly staffed, and it's there as a reliable hospital for you. So I think that's a very good message to remember. I heard some support and some suggestions for more procedures and more work that could be done at the Horton, and I think that's really good to hear, and we've got that feedback. I heard quite a lot about, which has happened in other consultations, about social care homes, about support for people at home, and the concerns that are there. So I think we need to be thinking a lot harder about how we do that with our council colleagues. And I think a bit more clarity about the timescale about the diagnostic centre and the investment in the Horton. I think we've talked a bit about that, but I think the more we can get of that, the better. And that's something which I think we'll be returning to. You know, what's the investment that's needed and what's the timescale for that, and we'll try and get a lot more clarity on that. And then again, a lot about transport, particularly parking, but also public transport as well. What we can do about that, and how can we work with local authority colleagues again to try and improve that. But again, thank you.
And again, on the transport issues, as in all these issues, there are ways in which you can suggest or propose or comment, and I'll come back to how you can do those at the end. But obviously the transport here has been quite a big issue this morning. And lastly, the Chief Executive, David Smith.
Thank you. So I just want to say, what happens next? So we've got still a number of public meetings across the county, and then, as you know, another meeting in Brackley. I would really encourage people. Thank you for your comments, questions this morning. That's been really, really helpful. But please go on our website, fill in the questionnaire. You know, the more responses we get around our proposals, the more informed that we can be when we make a decision. The CCG board, the Clinical Commissioning Group board, intends on making a decision following consultation, probably in June, and that will be a public meeting where we will bring this all together. But as I say, please take the time just to respond to us. It's really, really important that we hear the views of the public. Thank you.
Okay, and to that end, I know there's a team, the back office, as it were, taking all these things on board. Now, these were handed out, I think, at the front, and at the back, on the back cover, I would just highlight the email address, the physical address that you could use for the Royal Mail, and also the social media ones, as well as the website. Thank you very much indeed for your attendance today. The next meeting is at Oxford at 7 p.m. on Thursday, and we are back in Brackley on March the 21st, that time at the evening. The only thing that's yet to be confirmed is where, but Thursday, the 21st of March in the evening. But as I said, for those, if anybody did hand in a written question or has any subsequent questions or put their hand up that I didn't get to, I apologise. But if you hand those notes in, they will go up onto the website and questions will be posted. Thank you very much indeed. Yes, you've got a quick question, have you? No, it's entirely my fault. I mistimed it. I thought the conclusion was going to take a little longer, but it didn't. All right, well, I don't know because people are starting to go, so it's vaguely distracting. But if that gentleman would like... Bingo. There we go. So the gentleman with the beard, I wasn't ignoring the gentleman to the left. I've actually answered his question. Thank you. Yes.
Being a local councillor, sorry. One of the panel touched on the Ramsey Centre, which is an very interesting point. And earlier we heard about the hope for increased diagnostic services in Banbury. I understand that there are moves afoot at the moment. The Ramsey Centre was actually to be closed at the end of last year, but it was given a 6-month extension. And the Ramsey Centre is possibly going to be closed fully for the kind of services they offer at the moment, hip and knee and all the other joint work that they do. And that's going to be closed in the summer, I understand, and the building is going to be handed back.
All right, let's ask the Ramsey Centre. I'm very keen to finish on time, so I think we've got about 4 minutes or so for the answer. The Ramsey Centre. Andrew...
Does the Horton and the JR have sufficient capacity to take on the wonderful service which the Ramsey Centre...
All right, for those who are putting their coats on and everything, Andrew.
There is no intention of closing the services that are provided at the Ramsey Centre. They are going to continue. Under the contract that goes back many years, the building can revert back to the trust. So it's at the moment we lease, as it were, the building to the Ramsey, and that was the nature of the contract that was established. That contract ran out last year, as you say. We have extended the contract once, and we're currently in discussions with the CCG and with Ramsey over how we can continue to provide the best possible orthopaedic care, but also, as I indicated earlier, how we can sweat the assets more and possibly start moving some of those 90,000 patients back up to the Horton before we've built any new facility. So we're discussing those with Ramsey and with the CCG now. There is no intention of curtailing any of the services that are currently provided there. If anything, we're looking to expand them in the short term.
All right, for those who put their coats on, and thank you very much indeed.